Dr. Richardson,
Thank you very much, Lucia. Yes.
Wonderful.
Just needed a moment to unmute myself. It's a pleasure to be here, and my thanks to the organizers for inviting me to participate in what's really been a very exciting conference. I have no conflicts to disclose. My research has been funded by a variety of federal and non-governmental organizations. I have a lot of professional affiliations. However, I am speaking for no one but myself during this presentation. I am an emergency physician, and so I do want to make one last acknowledgement. I have, since March of this year, when COVID-19 arrived in New York City, been caring for patients with COVID in the emergency department. And I just want to acknowledge my colleagues in emergency medicine across the country, particularly those currently seeing in California the kind of surge that we saw here in the spring. It really is remarkable the degree to which the healthcare system has responded to this crisis, but none of us have ever seen this kind of devastating influx of very sick patients. So I'm going to talk a little bit about climate-related emergencies. I am, after all, an emergency physician and emergency preparedness. I'm going to talk a little bit about COVID-19 disparities. We've heard quite a bit about that already today, but perhaps I have a slightly different twist. I'm going to talk a little bit about the structural causes of racial inequities, and then leading into our panel, really think about what is it we should be doing now in light of all of these conditions. So extreme events, whether it's hurricanes or tornadoes or wildfires or heat waves, disrupt infrastructure. They disrupt power systems and transportation systems and communication systems, and they disrupt healthcare delivery and emergency response services. And all of these disruptions disproportionately impact on vulnerable populations and communities for a number of reasons that I'm going to discuss over the next 20 minutes or so. And I want you to keep in mind that the health impacts include not only the deaths and injuries or illnesses that occur during the event, but also the exacerbation of underlying medical conditions that happens because of the disruption of the healthcare system, and then the persistent and lingering adverse effects on mental health that you see after these kinds of emergencies, and that I believe are going to be one of the most important sequelae of the COVID pandemic, is really dealing with the mental and emotional well-being issues, particularly in minority communities. So why do extreme events disproportionately affect racial and ethnic minorities? Well, it is because there are long-standing disparities in health, and so these individuals are more likely to be susceptible to whatever injuries or illnesses are part of the current event. There are weaknesses in the infrastructure and services in many of our communities that precede the climate-related emergency. There are limited financial and social resources, and there's decreased capacity to be able to deal with the disruptions that often follow and linger after these events. So this, I guess, is sort of a central thesis to this talk, that racial and ethnic minorities live in physical and social environments that lack the resources needed to generate and sustain health. And they also receive less access to healthcare and poorer quality care compared to whites. This is the status quo over which climate-related emergencies then overlay their destruction and disruption. And so for those of us who are involved in planning for emergency preparedness, It's not enough to make sure that you're providing culturally and linguistically appropriate messaging before, during, and after the event. Disseminating information is not enough. We really have to be working with community organizations and institutions to build community capacity. We have to invest in community infrastructure, in housing, in roads, in access to broadband, in all of the kinds of infrastructure that are required to help a community survive and then recover from climate-related emergencies. Many of you may be familiar with this graphic, which really talks about the difference between equality and equity. As public health practitioners and healthcare providers, we are often in the business of giving out the boxes. And if you look at these kids on the left, the only one who really benefited from being given a box was the child in the middle. This one didn't need it to be able to see what was going on. And this one still doesn't have access to the view over the fence. And so giving everybody the same thing when their needs are different is not equitable. And so when you're in charge of giving out the boxes, think about what is it that needs to be done to make sure that everybody has at least an opportunity to participate. And it's more even, it's not even that everyone is starting as in these pictures from the ground. The reality today, when you look at racial and ethnic minorities, is that some people in this country have many more boxes than they need. Some barely have enough to get by, and some people are really already in a deep hole. And we have to keep this in mind. This is what we mean when we say we need to look at everything with an equity lens, so that when we're doing our work, whether it's healthcare or public health, emergency preparedness, research, teaching, whatever our work is, this is the reality of where we are today in this country. So let's talk a minute now about COVID. It's a public health crisis. It's an economic emergency, and it is an elevated threat to Black and Latino and Indigenous peoples of color and their communities. I don't have to show these statistics. This is as of this morning, the global numbers and the US numbers. And you know, the sheer magnitude becomes staggering. Yesterday, for the first time, we exceeded 4,000 deaths in this country from COVID. And that means that one person is now dying of COVID every 30 seconds in this country. And again, even with the magnitude of what's happening, again, there are certain communities that are being disproportionately affected by this pandemic. These are rates of COVID cases. This data is from the COVID Racial Data Tracker at Boston University. And you can see that Native Hawaiians and Pacific Islanders, American Indians, Alaska Natives, Hispanic, Latino, and Blacks all are much more likely to contract COVID than whites. And then when you look at who's dying from COVID, I draw your attention again to the two heavy, the dark blue bars, that Blacks are dying 1.6 times the rate of whites from COVID. Again, where does this come from? What are the mechanisms and the underlying causes of this disparate racial impact that COVID is having on Black and minority communities? It is the longstanding structural inequities, the pre-existing healthcare disparities, the community disadvantage that again leaves communities less able to respond, and of course, unequal access to healthcare, which is a major issue for Blacks and Latinos and other people of color in this country. So are why are these racial and ethnic minorities more likely to contract COVID? Well, they're much more likely to work in low-wage, high-contact jobs. They're more likely to live in multifamily, multi-generational households that have a greater number of individuals per household, living in densely populated areas. And so you have people who leave their multifamily, multi-generational household, and they have to take public transportation to go to their low-wage, high-contact job where they interact with members of the public. And so this sort of basic epidemiology that they have greatly increased exposure and so are much more likely to contract COVID. Racial minorities are also more likely to be among the most vulnerable groups. They're more likely to be incarcerated. If you haven't read the literature about the risk of being incarcerated in terms of your risk of contracting COVID, I refer you to several publications that have come out over the last year. The numbers are staggering because prisons are crowded. They don't have proper protective equipment. People are not able to social distance, and they have become really breeding grounds for COVID. Homeless people, similarly, homeless shelters are often crowded, unable to social distance, no equipment. For those BIPOCs who actually own their own businesses, they are much more likely to be in the hardest hit sectors in terms of businesses that are failing in COVID: leisure, hospitality, construction. And so these are the reasons why we are seeing disparities in who contracts COVID. The disparities in mortality have similar underlying causes. People are more likely to have underlying medical conditions that make them more susceptible to poor outcomes. They're more likely to live in areas with poor air quality, which exacerbates the respiratory failure, less likely to have insurance, less likely to have paid sick leave, and so may be more likely to not seek health care early, more likely to be food insecure and financially insecure. And so again, all of the things that are needed to sustain health, they are much more likely to have those resources, even less likely to have broadband in their home so that they can keep abreast of public health messaging and take advantage of telehealth visits to physicians. So where does this come from? And so I'm going to talk for just a couple of minutes now about race in America. I could tell a story about any of the racial and ethnic minorities who are disproportionately suffering from COVID, but I'm going to focus now on a tale of Black and white. Obviously, if you're going to talk about race in America, talking about Blacks and whites, you have to start with slavery from the 15th to the 18th century. Hundreds of thousands of Blacks were kidnapped from Africa and brought to the US as slaves. This is an institution that was codified by the US Constitution in 1787 and was the law of the land for almost 100 years. After the passage of the 13th, 14th, and 15th Amendments, that ended slavery, we then entered an era of legal segregation where segregation was codified in state laws restricting access to education, to jobs, to housing, to transportation. In the middle of the 20th century, when social unrest forced the end of legal segregation, we then entered the era of de facto segregation, which is still where we are today. And this era is not as far behind us as we might think. The last state law prohibiting interracial marriage, for example, was repealed in the year 2000. So within the lifetime of almost everybody who is on this call. And the legacy of this history we see today. We see it in long-standing, persistent disparities in health, in every health indicator that we measure, differences between Blacks and whites. And for all of the conditions that are related to environmental hazards and to climate-related issues, the legacy of residential segregation is really startling. For those of you who may not have seen these data before, this is something called the dissimilarity index. And the way this is defined is this is the proportion of the minority population that would have to move for both groups to be evenly distributed over a given geographic area. And the gold standard is this bar on the left. This represents South Africa under apartheid, which was essentially a completely segregated society. And as you can see, there are quite a number of American cities which approach levels of residential segregation that approach South Africa under apartheid. This pattern of residential segregation is the legacy of how Blacks came to this country. And you can, this is publicly available, you can look it up for various geographic areas and for various minority groups. So we know, certainly the people who are attending this conference know that where you live affects your health in so many ways. And we know that where you live in this country is still largely determined by your race and ethnicity. And so it is the combination of these two facts that lead us now to a conversation about racism. And, you know, I've been doing this a long time, and I have heard the term structural racism being voiced by more people over the last year than probably my entire life before that. But there is a growing recognition that racism is a part of our society, and it is at the root of the kind of racial and ethnic disparities and impact that we are seeing with COVID. COVID shone a spotlight on what, in fact, has been going on in this country for centuries. This is the work of Kamara Phyllis Jones from decades ago, where she defined racism as a system of structuring opportunity and assigning value based on the social interpretation of how we look. So race as a social construct. And what's interesting is the recent growing recognition that racism not only unfairly disadvantages some individuals and communities, it unfairly advantages other individuals and communities. Of course, it saps the strength of the whole society due to wasted human resources. And Dr. Jones goes on to give us these three categories of racism. And this first bullet really talks about the structural racism that we're now hearing so much about. Institutional racism is really differential access to goods, services, and opportunities based on race. And these are due to policies and practices that are embedded in our society, in our institutions, in our organizations, and even people who do not practice personally mediated racism, that is the differential assumption that some races are inferior to others, have been complicit in the perpetuation of institutional racism. And I think we're at a moment in time where perhaps that is about to change. So back to COVID, where does that leave us? What now? So much for the history lesson. We obviously have to find the path forward. What should we be doing now? Obviously, we need to assure equitable access to testing. And please keep in mind the graphics about what does equitable mean. Assure equitable access to the vaccine and assure equitable access to healthcare. This third bullet is something that we've been working on for many decades without success, but the imperative to start to get it right is even more compelling now. And in terms of longer term initiatives, we have to deal not only with the immediate health consequences of COVID, but also with the financial devastation that it has wrought, because that financial devastation also have health impacts. We need to be partnering with community organizations, those bodies and organizations already trusted by community members. We need to provide financial relief. Perhaps many of you saw the JAMA research letter showing the health impact of actually receiving unemployment insurance benefits during the COVID pandemic. And we need to engage in financial and logistical disaster preparation so that our communities are not left as vulnerable as they were to COVID when future emergencies arrive. So I leave you with this quote from Nancy Krieger, a sociologist, social epidemiologist, because it really is about making sure we keep in mind, whether we are doing emergency preparedness or public health practice, or we're healthcare providers, integrating all of the things that this conference has talked about. We need to keep in mind and think about in an integrated way. We are both biological and social organisms living in an environment which is both physical and social. It's never either or, it's always both and. We can't afford to have any discipline to engage in reductionist thinking. Everyone has to start keeping all of these issues, all of these influences in mind as we craft solutions and find a way forward. Thank you very much for your time, and I'd be happy to take questions if there are any.